From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello and welcome to our listeners around the world. You're listening to JAMA Clinical Reviews podcast. Thanks for joining us. I'm your host, Dr. Margaret Wheeler, an associate editor at JAMA. We're joined today by Dr. Lara Dunn to discuss her clinical review on head and neck cancer. Dr. Lara Dunn is of the Head and Neck Department at Memorial Sloan Kettering in New York City. Thank you so much, Dr. Dunn, for being with us today.
Thank you for having me.
So, Dr. Dunn, just to start off, tell us what is meant by head and neck cancer. Is that any cancer in the head and neck?
In general, when we speak about head and neck cancer, we're speaking about cancer that arises from the lining or the mucosa of the upper aerodigestive tract. That includes the nasal cavity, the paranasal sinuses, the oral cavity, and just posterior to that, the oropharynx. And as we move inferiorly, it includes the larynx, which then becomes a respiratory tract, and posterior to the larynx, the hypopharynx, which then moves into the digestive tract. For the purpose of our review, we did not include nasopharynx cancer. The review focused on the non-nasopharynx head and neck cancers.
Okay, and how common is this kind of cancer?
So head and neck cancer, it's the 7th most common cancer worldwide. In 2014 in the U.S., there were over 70,000 new diagnoses and over 16,000 deaths were due to head and neck cancer.
And who gets this kind of cancer? What are the risk factors for it?
So worldwide, tobacco and alcohol use are the most prevalent risk factors. We know that the number of pack years does correlate with the risk of developing a head and neck cancer. Also, in the United States and Europe, a subset of head and neck cancers called oropharynx cancers are predominantly driven by HPV or the human papillomavirus, the same virus that causes cervical cancer in women. And now 60 to 70% of oropharynx cancers are caused by the human papillomavirus.
So interesting. You said that the number of pack years makes it riskier for a person to develop this kind of cancer and that smoking and drinking were important as well as HPV. So are there ways of mitigating the risk? And even if you have early cancers and you decrease your drinking and smoking, does that help?
Yes, it does. Smoking as well as alcohol cessation does decrease the risk of developing a head and neck cancer. And we even see that in patients who stopped smoking and drinking many years ago, that their risk returns to the same risk as the average population.
How about HPV vaccination? Does that help?
Right now, we know that in those who've been vaccinated for HPV, we have seen that high-risk HPV in oral saliva has become undetectable in this population. It's too soon to see the incidence of oropharynx cancer decrease, but we do think that vaccination will play a significant role in decreasing the incidence of HPV-associated oropharynx cancer in the years to come.
So that's fascinating. Does that mean that we could, say, screen people for the cancers by seeing HPV or doing something else?
Right now, there's no screening for head and neck cancers and HPV-associated oropharynx cancer. HPV exposure is fairly ubiquitous. A lot of the population will have circulating HPV within their oral secretions or saliva, and only a minority of people who have been exposed to HPV go on to develop oropharynx cancer. So currently, we don't have a good way to screen for HPV-associated oropharynx cancer.
So it's so interesting that there are these two different types, HPV and non-HPV associated cancer. Is it important for us to distinguish between those two?
It's important to distinguish between the two for a couple reasons. One is that the prognosis of HPV-associated oropharynx cancer is definitely better compared to HPV-negative oropharynx cancers, and it may affect the aggressiveness of the treatment given the prognosis. Additionally, patients who have non-HPV-associated head and neck cancers, oftentimes driven by tobacco and alcohol use, they're at much higher risk for developing additional primary head and neck cancers. And so it is important that those patients especially are followed up by primary care physicians, ENT physicians, or head and neck surgeons to make sure that a thorough exam is performed at a regular cadence to screen for additional primary cancers throughout the upper aerodigestive tract.
Interesting. Okay. How does the head and neck cancer typically present?
There really isn't a typical presentation given that there's many subsites, as mentioned, throughout the upper aerodigestive tract, and the presenting symptom tends to depend on where the cancer arises. So cancers that arise in the oral cavity tend to present with oral cavity pain, bleeding, sometimes dysarthria, or slurred speech. Cancers of the oropharynx oftentimes present with pain with swallowing or difficulty swallowing. There can also be referred pain to the ear. That's called otalgia. Patients who present with cancers in the larynx, they can oftentimes present with voice hoarseness. Sometimes they also present with symptoms of aspiration. And so when I'm asking patients about the possibility of aspirating, I'll ask if they cough while eating. Patients whose cancers arise from the hypopharynx often present with progressive dysphagia or difficulty swallowing. Usually first it's liquids and then it evolves to difficulty swallowing solid foods and also pain. One thing I should say about HPV-associated oropharynx cancers is that it's very typical that these cancers present with a small primary, so oftentimes they're asymptomatic from the primary site, but they present with large neck nodes or cervical lymph nodes.
Oh, so a lymph node that you don't really know what the origins of that lymph node is could be coming from head and neck cancer.
Right. So 10% of the time, patients will present with what we call cervical adenopathy or enlarged lymph nodes in the neck. And on biopsy, usually it's a fine needle aspiration. It will return with squamous cell carcinoma, but the primary site is unclear. And oftentimes, these squamous cell carcinomas of unknown primary or head and neck cancers of unknown primary, we later find come from the oropharynx. And one way that we can be directed towards finding an oropharynx primary is if the biopsy is consistent with an HPV-associated squamous cell carcinoma.
So is it fair to say that since the presentation can be so diverse, if there's a lymph node that you don't know what it is, you should go ahead and get an FNA of it. But if there's a lesion in the mouth or something like that, you get a biopsy. But otherwise, if we're suspecting that there could be a head and neck cancer from all of those symptoms that you described, we should be sending our patients to you or to a head and neck surgeon, to a ear, nose, and throat specialist?
Yes, I'm a medical oncologist. I'm usually not the person who diagnoses these patients. Usually these patients are seen by an ENT physician or a head and neck surgeon to make the diagnosis. If a patient presents with one of these symptoms or cervical lymphadenopathy without symptoms arising from a clear primary origin, it would be best to have a head and neck surgeon perform, we call an endoscopic exam with a nasopharyngolaryngoscopy, unless there's a clear oral cavity lesion. The primary site should be biopsied if possible. Sometimes that does require taking the patient to the operating room. Additionally, a diagnosis can be made if there's an obvious primary and the neck nodes are more easily accessible to biopsy through an ultrasound-guided fine needle aspiration. Additionally, patients should have high resolution imaging with a CT of the oral cavity or neck or an MRI of the oral cavity neck to evaluate the primary tumor. And then full staging imaging is usually with a CT of the chest or a PET CT.
Okay, great. So now if we've made the diagnosis of head and neck cancer, what are the common treatments?
The common treatment is really guided by the stage, or we call the extent of disease at presentation. I think of head and neck cancers as presenting with one of three different stages. There's early stage disease, which is a small primary tumor without regional lymph node involvement or neck node involvement. There's locally advanced disease, which is either a large primary tumor or a primary tumor that invades onto surrounding structures and or is associated with regional lymph node involvement. And then the third stage or category is the more advanced stage with either recurrence at the primary site or regional lymph nodes or cancers that have spread distantly throughout the body, such that metastatic disease is present. So for early stage disease, it's usually what we call single modality treatment. And when we think of a modality in head and neck cancer, it's surgery, radiation, and systemic therapy or chemotherapy or immunotherapy. With early stage disease, it's usually surgery or radiation. With locally advanced disease, we treat with at least two modalities. So it would be surgery followed by radiation and sometimes chemotherapy with radiation after surgery. Or it could be radiation with concurrent chemotherapy. And we would then reserve surgery for if the cancer were to persist or come back. And then for advanced disease, it really depends on where the disease is. If it recurs in the head and neck area, if the patient was treated with surgery, we often see if we can give radiation with curative intent or vice versa. If the patient was already treated with radiation, we see if salvage surgery is an option to still cure the patient. Otherwise, if the surgery and radiation are not options or the cancer has metastasized, we treat with what we call systemic therapy in the form of chemotherapy or immunotherapy or sometimes targeted therapy.
Interesting. So are there things that you would recommend that primary care physicians or providers be alert to as their patients are going into these kinds of treatments? Are there dental procedures or vaccinations or other things that you think should be done prior to treatment to help assure better outcomes?
Yeah, good question. So prior to treatment for head and neck cancer, we do have patients meet with usually a speech and swallow therapist. It's important that our patients are able to do swallowing exercises such that they can preserve the function of their swallowing muscles. It also helps to maintain nutrition as well throughout the treatment. So early referral to a speech and swallow therapist is important. We do refer our patients to dentists, especially if patients are undergoing or plan to undergo radiation-based therapy. And the reason for that is that any teeth that are decaying need to be extracted because after radiation, we try to avoid dental extractions given concern that the mandible or the jawbone is weakened. And we can further compromise the integrity of it with having to extract teeth. Additionally, with radiation, we compromise a lot of the minor salivary glands throughout the upper aerodigestive tract. So there's loss of saliva, which is protection against dental decay. So getting patients in the habit of good dental hygiene is important going into treatment.
That's great. Let's just close out with having you tell us a little bit about the prognosis for people with head and neck cancers.
Thank you. So one of the reasons that I really do love practicing as a head and neck oncologist is that the outcomes can be good, both curative outcomes as well as functional outcomes, but I'll focus on the curative outcomes. So for early stage disease, the 5-year overall survival ranges from 70 to 90%. For locally advanced disease, it's quite a range because it depends on the subsite and the stage, but the 5-year overall survival is anywhere from 25 to 60%. And in patients with HPV-associated oropharynx cancer, that carries a really good prognosis. And over 85% of patients are alive at 5 years from the time of diagnosis. For patients with recurrent and or metastatic disease, which is more a minority of head and neck patients, the overall survival at 5 years is less than 20%.
I have one more question, and that is, given that there can be some pretty good survival rates, how do generalists follow, or how do you follow people who have been treated initially to make sure that they continue without recurrence? Do you have certain ways you suggest that people do surveillance?
Yeah. So the surveillance following a diagnosis and treatment of head and neck cancer is well outlined in the NCCN, or National Cancer Comprehensive Network guidelines. Our patients following what we call a definitive or curative intent management all have a PET scan at around 3 months or 12 weeks following completion of treatment. And if the PET scan shows that there's no cancer, that the patient's disease-free, we continue monitoring the patient per the NCCN guidelines. We do not do routine imaging following the PET scan. We also check thyroid function tests at least every 6 to 12 months because the thyroid gland is in the radiation field for patients who've undergone radiation, and over time, hypothyroidism can develop. I do ask about dental cleanings. I also ask about the acute and chronic sequela of treatment, depending on what treatment the patient received. And then we do screen patients for depression and suicidal ideation. And then the last thing I should say, we do follow patients, usually 3 to 5 years, 5 years per the guidelines, before handing our patients off to the primary care physician.
Thank you so very much, Dr. Dunn, for joining us today. I'm Dr. Margaret Wheeler, and I've been speaking with Dr. Lara Dunn about head and neck cancers. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.